All right, so I am Brian Betts. I'm here with Kristen Sims, Sean Dagerstrom, and Josh Bush. We are all a part of the DAT 2018 athletic training cohort for ISU, for Indiana State University, for those who don't know what ISU stands for. And we're just going to be going over some manual therapy techniques today that we learned for the ankle and foot, and then kind of discussing a case that we have. So, Sean, do you want to lead us off?
Sure. Can you see me, or did I mute my picture? So, all right. We'll start off. We're going to have, we'll start with ankle mobility. So I'm going to move over here. I'm going to turn on the light in the living room so you can see what's going on a little bit. So this is my wife. We're going to actually have her stand over here. We'll move the camera so we can see what's going on. So she's going, normally it would be better in the athletic training facilities if you were on a table, but we don't really have that capability at this point. So she's going to move this ankle forward, step back. We're going to be a little bit of lunge. We're going to set up the belt. Apply pressure. You can get a little bit up towards the calf and get it down. Here, we'll move this down that direction so you can see placement. So we're going to be right above the malleolus. We're going to lock in her foot, and she's going to lock in and rock forward like she's doing a lunge. Coming forward to lunge. And you apply pressure, going posteriorly with your hands, and you're applying pressure anteriorly with your belt, and then back forward, back, and rock again, and back again, and forward, and back. So you do that commonly 3 sets of 6 with that mobilization. My clinical experience is actually works really good. The other technique we'll demonstrate right now is going to be as a lock with the fibula. We actually use this ankle. So you have place here. So it's going to be just like you were before. Pushing feet. You're going to get your hand. So it's going to lock in the fibula, lock that into place. And you're going to have your patient do the same mobilization technique. Go forward and back. Forward and back. And forward and back.
Hey, Sean.
Yes.
Do you feel like you get a good, I haven't actually tried this one on anybody. Do you feel like you get a good grip on that distal fibula with your eminence, or do you feel like you need something else to kind of give that pressure?
I feel as though I get a good pressure. It's better for my body position if I'm having on an elevated table, but I'm not going to put anyone on my dining room table to do that tonight. So maybe my daughter, but not my wife or myself.
Yeah. Oh, for sure. I was just thinking like me doing that maybe on, like, I could see myself doing that really easily on maybe like a bigger like linebacker or something, getting my hand in there because their ankles would be bigger. But if I were, and I guess I just need to try it for myself, but if I were to put my hands on maybe like one of my cross country girls at the high school setting, that I feel like as soon as they moved, my hand would just slip. Because my eminence is probably the size of their entire side.
I don't have huge hands. I have strong hands. So if you lock your hand in place, and that it's sort of just literally, it's like jab right there. You just don't have to grip like this. You'll sort of lock in place.
So you didn't, I thought about that after you said that. Do you put your hands around the back, like around the Achilles, or do you just have your hand right there?
I just have my hand right there.
Okay.
And I don't push around. The pressure is really right through the part.
Do you think it would be bad if you put your hand all the way around to grip?
I don't think it'd be bad as long as you're not pinching and gripping.
Mm-hmm.
So
I think it's something to try.
Do you guys know like any of the research behind that technique specifically? Like I know there's a lot on anterior posterior talar glides and stuff like that, but with the fibular glide, are we assuming that the fibula gets like adhesions and stuff built around the ligaments and stuff that keep the fibular head like anteriorly stuck, or what?
Yeah, from the research I've read on this is actually not what has been assigned recently, but the research I've read on that particular technique, it's about the same as the other manual therapy procedures. It was more of a case report, so level of evidence is really low. but they found that you have increase in the physically active scale with the procedure and increased range of motion as a clinical rated outcome after a series of the one case series was 2 weeks, 3 times a week. So increased range of motion was about 15 degrees after a acute ankle sprain. So did the ankle itself get better, or was it the manual therapy that caused it? It was kind of a very poor study, but it sort of highlighted that. And so actually one of our assignments that we're doing for long term, this would actually be kind of unique to see if it does make the effect.
So I have kind of a cool case. So I just had actually it's not cool at all. It's probably fairly normal, but so I had like a grade 2. It was definitely past a grade 1 lateral ankle sprain earlier this season or this semester. It was a girl and it was a volleyball player, and it was her like 3rd or 4th time spraining that ankle, and it had swelled up like within the first 5 minutes after it happened. Like it was fat, full of fluid. Well, the first day after I started doing, I just grabbed our TRX band. No, I grabbed our it was just like a resistance band, but it was a pretty heavy resistance band. Put that right on her, the anterior part of her talus, and I started doing the anterior posterior mobilizations with dorsiflexion. And that was the fastest, like the fastest rehab to be able to start doing functional training and stuff like that I've ever had on a person. It wasn't like 5 days before she was able to start doing line hops, like single leg stuff, single leg hops and stuff like that, like with full trust in herself. And she said no pain. I was like, I got to start using that all the time.
It's quite remarkable how well these glides work for the ankle. I started using them about a year ago because we had a series of ankle injuries on the football team we're working with, and this that technique combined with some high velocity stuff that was being shown by a physical therapist got the athletes very functionally ready. I wouldn't say that their ligaments were prepared for some of the stuff, but they were at least able to train and get back to activity far sooner than waiting for that ligament to heal, then recondition them. So it's quite remarkable what these glides actually do. So what you're describing, I've seen that several times as well. It's quite remarkable.
Yeah, it's cool. But I guess it kind of brings up a challenge as you start seeing these gains super fast, and it's probably fairly tempting to get them back in. She was out. I mean, I'll admit, like I started taping her up for practices again about 2.5 weeks out after that. But I mean, within the first week, she was able to start doing functional stuff. So I got to assume that she was healing, fairly quickly.
Kristen, going back to what you said, I was doing the fibular mob on a patient who just had a lateral ankle sprain, and his ankle was so swollen up that my hand kept slipping off, kind of like you talked. And he had pretty big ankles too, but I still kept slipping off. One thing that I found that was helpful was either just like sticking a piece of tape, because you can kind of get more of a grip on it. So there's like a small piece of tape, or even just spraying tough skin to really making it hard to slide off.
I didn't even think about that. That's actually a really good point.
That's a good point. And Brian, Kristen, for me, the few times I did it, I slipped off. Is sort of learning how to get a grip and catching that in. It's hard to describe without some practice. But the first few times I did it, I slipped off as well. So don't take that as a slight that you're not doing it right. It just takes a little bit of comfort from yourself to get that lock in place so you can do those techniques. But I do like the idea, Brian, of tape and adhesive spray. That's a really good tip.
I guess if you guys, I can go next if there's no more questions. All right, so I have my lovely patient Matt here. So just going over the femoral neural tensioner and glide. So I'm going to have you lay just on your belly. Put your head on this end.
My head on this end?
Yeah.
Okay.
Yeah. Can you guys see that okay? So hanging out, he's kind of slumped over the edge, which you can kind of see. And then we'll just bring him up almost into like a rectus femoris stretch. So he's actively going to bend his knee and then lift his knee off the table. And so this is going to be a tensioner, because you can relax if that's uncomfortable, because it's getting keeping his nerve stretch. So his spinal column with his neck inflection is kind of elongated. And then once we kind of pull that knee back and that knee off the ground, he then keeps that in a stretch. I haven't personally used this yet clinically, but I can imagine it probably works great for, especially in Josh, Chris, and my setting, high schoolers that are constantly sitting down, or soccer players, or catchers in softball or baseball. I'm assuming would be extremely useful. And then looking more into a slider technique, trying to get the nerve to move within the nerve bed and get some excursion going. So I'd start with him in this position with his neck kind of flexed and kind of slumped over still. And then as I'm going to have him extend his neck, I'm also going to have him bring his knee or his heel to his butt and then lift his knee off the table, get him into some hips extension, knee flexion, and then transition back slowly at the same time. Yep. And then he just repeat that process probably 6 times for 3 sets.
I have a question, or maybe it's an idea, and I just asked Riley because he's just in the room, and I didn't know if it was dumb or not. But if they're doing this, the second one that you just showed, so the glide, if they're having some like SI joint pain while they're doing this, that may be kind of painful, like getting into that full, the full position, the ending position. Would it be possible or even a good idea to do like a sacral mob at the same time? Like if when the full position to do the anterior pressure, you know what I'm saying? Does that make sense?
You kind of cut out. So
No. I was saying whenever they get into that full position, so when Matt is completely hip extended, knee flex, head and extension, if you apply a downward pressure on their SI joint, because some of like a lot of my younger girls, like my track girls and my cross country girls, have a lot of SI joint dysfunction. So if I apply that downward pressure, then I can get an actual good femoral nerve glide. Or do you think that would disrupt the purpose of it?
that's a good question.
Here's my thoughts on that. As we went through last semester, that anatomic correction was so critical at doing other items. So if we did the anatomic correction, getting the pelvis in the right spot, you then can go into that nerve glide to increase mobility with that. Sort of same idea that you're thinking, Kristen, applying that downward pressure while doing that. You could, in theory, maybe apply that. That'd be a question for Dr. Powder that we could ask. Would that be beneficial? But my for clinical practice, I was doing first, then apply the femoral nerve glide.
I like that. I didn't even think about doing it before, and maybe getting rid of that pain or discomfort that they're having at the SI joint and then doing this isn't a bad idea.
Yeah, I like it. Okay, so do you guys have anything else to say about femoral? Okay. Then I'm going to go ahead. I'll kind of show you guys how to tension and do some glides for the sciatic nerve. So typically you would have them sitting in like a chair or something like that. So actually I may have Taylor sit here. So just sit, and I'll lower this so you guys can see her. Hi. Maybe I can lower it enough. That's too far. Okay, that's not bad though. Scoot back a little bit. Right there. Okay. So just to go ahead and tension it, the sciatic nerve obviously is going to run straight down the back. So if you want to put it on tension, we're going to have her straighten out this right leg, dorsiflex at the ankle, and then she's going to drop her neck down towards the floor. And then if you want to add additional tension, you can have her curl her entire upper body just like that. Do you feel any kind of tingling or pain that's going down the back?
No. I mean, it's stretching for sure.
Okay, that's not bad. Okay, so go back. So now in order to do the glide, so we're going to want to tension that one side and we're going to want to slack at the other. So she could start with her neck down just like this, and then she could go straight leg out, and then just adding the, and this is probably a little bit more advanced, the one that Dr. Proudman showed. I'll show that one first. It's where she will look up with her neck at the same time as going into knee extension and then adding dorsiflexion at the ankle. And then she would return this down to the ground as her head goes back down. So we have tension here, slack here, tension here, slack here. And then full tension like I described. Well, then there's the neutral where she's going to stay neutral in the neck. She's not going to move that at all. And then she's just going to have tension, and then she's going to be in neutral. So she'll knee extension, ankle dorsiflexion, and then she's going to return. And that's going to have that glide go while she's still in a neutral position.
As a person who has had sciatic problems for damn near 20 years, gradually progress someone with that one, because I know what would happen, but I was like, well, how bad is it when I go to that advanced one first, and I have shooting pain down my butt and to my foot right now. So if you have someone with that, start progressive, then go, because when I'm having bad days, I tend to do this to have a lasting relief for a day or two, and if I do, then I have to do my exercises. Otherwise, it doesn't matter. But that's one thing to keep in mind with this technique.
Right. So I guess what I was starting to say before I kind of moved on was for the original glide, instead of going and instead of adding both knee extension and dorsiflexion, just adding knee extension and then keeping the foot plantar flexed, and then having at this point your neck would go back to like glide, and then you would go down at the same time, and then come back up, and then you can progress to adding the dorsiflexion along with that. Is that what you're talking about, Sean? Okay.
Yes.
I found, doing some research on this, I found a cool I guess I'll call it neuroflossing technique. I don't know if you guys have stumbled upon it, where essentially it's almost like a hamstring stretch. So I'll try and demonstrate and talk you through it at the same time. But so if I just kind of lay right on my back and then get myself into a hamstring stretch, or hold the back of my knee, and I can kind of bring my torso up and then kind of go into this position and do the same kind of technique with supine position.
I use that all the time as a part of a warm up for a lot of my athletes. I have them stretch or do bikes or stretch bike and then that, and it's amazing.
I had a belt with that as a tendency in my hands. I use a belt behind it and it worked pretty good.
Cool.
Brian, you should share that article, so that might be something we might need for our 2-week assessment project.
It was more like a picture on Google, but
we still might.
I didn't say it works, just on my phone.
We still might need it.
Okay.
Okay.
Kristen, you wanna go?
Yeah, I am going to show y'all the plantar fascia clearing. So go ahead and flip over on your back, like sit down and give me your phone.
I didn't know what I was doing.
It's fine. So this one, you're gonna have them lying. He had them lying prone. I feel like for this sofa situation, I'm gonna have them seated just so I can show y'all his foot. I just realized I was gonna have to touch your foot. And then I'm gonna slide my thumb from the base of his first toe to the 5th metatarsal and then all the way around. So it's gonna make almost like a moon shape like that. And then to get better force, I make it on top like that. So I'm gonna go all the way down, around, and then swoop out like that. Could y'all see that okay? Oh no, because you can't see. So I'm gonna come here, out to the base of the 5th, and then I like to apply a little bit of extra pressure with my other thumb over thumb, to the end, over the medial calcaneal, and then out to the side, just like that. Do you have any questions about that one?
Yeah, I have a question. How's that?
It feels pretty good.
The next one is going to be the positional release for the Achilles. So you're going to have them lying prone, and then lie prone. And then for the sake of this, scoot over a little bit more. I'm going to be right here so you guys can see. And then what I'm going to do with one hand, I'm going to find that really tender spot on their Achilles. I'm going to get on either side of it with, in this case, it's going to be my left hand. So I'm going to get on either side of right there. And then I'm going to either lift or just pinch. And then I'm going to move their foot into a relaxed or slack state. So whatever is comfortable for them. So for him, do you have any pain in your Achilles? Right here. And then I'm going to move him into slack. And then if I feel him start to release, Dr. Powden says about 30 to 90 seconds is a normal pressure time. So I'm pinching or lifting that Achilles on that tender spot with the foot in a slack position. And then about 90 seconds, I can move on to a different spot. And then you can move, you can reassess, glide your hand over it, do a new spot. I haven't had this one done to me. How does it feel? Does it actually feel good?
It does feel pretty good. But I like that digging one. I don't know. I just like push on it. Like, see, that feels pretty good.
Yeah. Okay, so that's what, Brian?
I've never done like before, but positional release is probably one of my favorite things to do, like any.
Yeah, I wasn't sure what to think. Like when I first was going over the techniques and I just saw the title to this one, I was like, I don't know how I'm gonna do that, but whatever. But it's actually kind of a cool idea, and I haven't thought about it. I've never used it until now. But it's kind of a cool idea. I'm gonna go on to the next one, which is gonna be the bending technique at the gastroc. So I'm gonna have you flip over like I did for your video. Yeah. So usually you would just have them lying completely on their stomach. But just so you guys can see a little bit easier, I'm going to have him a little bit turned so y'all can see his gastroc. So depending on which side of his gastroc is going to be that really tight side or the tight that he's having a trigger point or anything like that, that's the side I'm going to focus on. So I'm going to keep his leg in slack, so keep his knee a little bit flexed. So I'm going to prop him up a little bit. But just so you guys can see, I'm going to separate the two gastroc, and I'm going to get right in the middle. And then let's say that his trigger point or his most tender area is going to be right in that mid muscle belly. I'm going to try to pick that up right there. And then I'm going to push either down and then back up. And his is really tight, like how he was talking about in the video. That it may take I may have to do a couple other things before I go right into this, because I feel like I'm just moving your whole calf.
You're moving my skin. I can't feel my muscle.
Yeah, I can't get in there to separate the two. In the video, and he did this on my calf earlier, he literally could separate each head, and then you can see it bend on either side, and I cannot do that right here. It's just skin.
I think we got some bash.
But yeah, that's the idea.
So what do you guys think? You think like a grass pool as a that motion there? So they're using is it G1? That's the big one. So maybe using G1 to kind of dig in and separate that the medial gastroc, and then grabbing it with your hand, like kind of forcing it down with your thumbs and pinning it, and then grabbing the other side with your fingertips, and then kind of moving up and down like that.
Is that like similar to what he was doing with like the shoulder blade kind of? Like how he like scooped and then
Yes.
I think that would totally work. Or even one of the smaller ones, like if they're a smaller kind of dude, like getting in there with that and then putting your hand on the like most lateral part of the gastroc.
Yeah, I was thinking GT3, the long, skinny one, as partially with the plantar fascia, so I don't use my thumbs, and even separating, whereas GT3 or GT5, instead of the big bar, but something we can place with one hand and just separate as an idea. So I think you're onto something with that.
You could even do it to yourself. I was sitting here trying to see what the difference in like calf tightness was. And this is, I feel like you could do this to yourself really easily. Like if you have a patient that is just lighting up, like has a ton of calf issues, this is something really easy to incorporate into their home plan. Oh my gosh, yeah, I can see that.
Yeah, yours was a good one.
So what's the breadth scheme on this?
He didn't mention anything.
Hey, what do you?
He didn't mention anything, but I would assume it would be kind of like maybe a 30-second bending.
Okay.
And then moving on to a different spot. I don't know if we're like in the session that I was just in with Riley and Matt's group, they were talking about like working distal and going up. So working at like the lower insertion and then going all the way up to right behind the knee. And that being really like it felt really, really good for some of Riley's football players, and I think that that would be a good idea. But I would do like a 30-second at each different little tender point.
So did they said distal to proximal?
I think that's what he was talking about. Yeah, he would
When I
do.
did mine, I would do proximal. I would go gastroc head and then work down towards myotendinous.
So he did gastroc head and then down to the myotendinous. So I guess the opposite.
Yeah,
That's what my athletes like.
I would usually go superior to inferior on that, but I don't know if it would make a terrible difference. But you usually get more adhesions on for the gastroc at the proximal head, and then you would at the musculotendinous junction.
Yeah. Start in the muscle belly and then work your way down. What was it? Oh, the last one that he showed.
Toe.
The first MTP. Do you guys want me to show that one?
Go for it.
Okay, because so before I go into it, I used to have really bad turf toe in both of my first MTP, and naturally, like without knowing anything about mobilizations or anything like that, I would I'll let you guys see my nice feet. I would just if my foot would be on the ground, and I would just take my foot and I would just pull it out this way, and I would just keep pulling it towards the midline, just because like that's what felt good, and then so that's kind of the mobilization that we're gonna do here. I could probably just show you on myself rather than Taylor, so it's a little bit closer. But so what you're gonna do is, he said you would have your thumb on the inside of their toe, of their big toe, kind of here, and then you want your hand kind of supporting the medial border of their metatarsal. And so you got that supported with there. Put this with your thumb, and then have them go into extension, and then back down to neutral. And that's your mulligan movement there. And to me, that feels really good. It feels kind of unnatural, but at the same time, like I feel like I'm getting some action.
The thing I found with this one was that normally during these mobilization movements, you're putting a force either like you have the concave convex rule, so you're either putting a force with the direction of the movement or opposite direction of movement, but this one is completely perpendicular. It's kind of abstract, I guess, compared to what you traditionally think. I didn't know if any of you guys had any idea of why that is.
I honestly didn't even notice until you just said that.
It's not a Maitland mold that you commonly would do the concave convex rule. It's more that it's a mulligan type movement. So you're putting that mulligan's very big on the medial glides, whether that's the hip or whether it's other sides.
Good night, Dad.
Good night, Tom.
So having like you're saying at the hip, like you would do like a lateral distraction, so the band's pulling outwards away from the hip as you're going into this flexion and extension.
Yeah, same idea with the toe. So that's sort of his teachings, even though it's not Maitland, when Maitland's doing the concave convex rule. So if you're doing Maitland, you would be literally like that. You wouldn't be doing this. It'd be like that. So this is a good question, Brian, though. But with Mulligan, that medial glide, that medial pull is popular in hips, his feet, and elbows. I've seen some of the literature on that. So I don't know why it works, but it's a fair question we can ask Dr. Powden, see if he could, when we write up our questions, see if he can give us feedback on why that is the case.
Yeah, I like it. I was going to say something about it. So I also think that sometimes, I know for me, I have it a little bit, but a lot of my athletes, I think it's hallucis, is it varus? Whenever it's like the bunions are starting. So, I mean, if that's prevalent, then I mean, I guess this would be a decent stretch.
Alex valgus.
Is that valgus?
Yeah.
Oh, yeah. Yeah, my fault. So I guess that makes sense. Hallux, not hallucis. So do you guys kind of want to discuss our case a little bit?
Yeah. Do y'all have it pulled up, or have y'all checked it out or anything?
I just gotta pull it up.
I've got it pulled up here. Can we say good night to our patients?
Can we what? Say that again.
Can we say goodbye? Are they good?
Yeah, I think so.
You're good.
Unless y'all have any questions or want to do anything on other people. I'm pretty good with it. I was pretty confident with all of these techniques, other than the femoral nerve glide. I feel like I need a lot more practice, especially with instructing it. I don't think it's gonna be bumpy the first couple times I tell somebody to do it.
Yeah. Bend your hip. Flex your knee.
Yeah.
You're good. Thank you. All right.
I'm going to help you climb it too.
So I think that things that hey. Thanks. You echo a little bit. When I was reading over our case and I was looking over the techniques and stuff, I definitely think that the Achilles tendon not mobilization really. It's a
Positional release.
Position release. Yeah, that one, and then the bending. Holy cow, the gastroc bending. I think that those two are going to play kind of a big role in her healing here. But then also just her having some pain, like even if it's more distal inside of her Achilles tendon, I would have to kind of read a little bit deeper into the case again. But doing those neural glides and tensioners, just because one of the articles that Dr. Padnett also posted talked about those effects on Achilles tendon pain, and it was saying that they had some fairly positive outcomes just with that. And I think that kind of plays into that we should use that pain neuroscience or neuroscience pain education, just getting them to buy into the fact that their CNS plays a large role in how they're perceiving pain and stuff like that. And so if they'll buy into that, then neuroglides are going to have that much more of an effect, I feel like.
Yeah, based off the description, what immediately popped in my head was that there's some sort of nerve entrapment causing some of this. So the neuroglides, I would even consider outside of what we've talked about for this week, looking at doing an assessment of the pelvis to see if there's any SI gapping or anomalous correction that might be needed. And on top of what you already mentioned, Josh, I would look at doing the AP glide with the mobilization belt, because that has some good positive literature outcomes on ankle mobility, just doing that activity. Not necessarily the fibular lock, because we're not dealing with per se an acute ankle injury, but that mobilization may be beneficial too, is sort of an idea. But immediately, as soon as I read the case, I thought immediately that you need to get the sciatic nerve to be mobilized, and you know what, maybe there is a femoral nerve item too with that, but definitely something with the sciatic nerve, because a lot of times with that sciatic nerve dysfunction going down the leg, it affects the gastroc and Achilles quite prominently in your patient cases if you have that.
Right. And you said, we're not necessarily dealing with an acute lateral ankle sprain, but she did experience, it said, several ankle sprains during her college soccer career. So, I mean, she's probably a candidate for chronic ankle instability. It says that she worries about it, but she tries not to let it affect her. But obviously there's some kind of instability there if she's even thinking about it at all.
I was looking at that compared to what our inclusion criteria is for our study, and it pretty much matches up identically. So,
yeah. Well, there you go. That would be a big help. But yeah, so maybe the fibular glides will help as well, just to help. Maybe it helps to increase dorsiflexion a little bit, because it says it's bilateral. So whatever kind of mobilizations we can get going. But so what kind of filter do you guys think that we should put these mobilizations and just manual therapy techniques in general? Would you guys start with maybe the positional release, or possibly the neuroglides?
I personally would start with some soft tissue. What gets the tissue to be mobilized more of that specific area? So the positional release or the bending would be first before I would go into the neuroglides. Neuroglides is what I would sort of end end with my manual therapy session. But anything you get the soft tissue to feel more relaxed, get that relaxation so we can get a full range of motion with our tensioners and slack motion, that probably be quite beneficial.
So I kind of like the idea of kind of desensitize the area first. That's kind of why I was thinking like positional release is it's just like you put them in a position of like pain-free motion or pain-free just position, and then kind of get them to trust, like give you a little bit more trust throughout the next couple of exercises and manual therapy techniques that you're using. Just adding on to that whole kind of control on their central nervous system and how it's responding to stimulus.
Just to pull us back a little bit, I was just looking at the document for the assignment description. We're supposed to come up with a treatment plan next week. This week is more like what we did last semester, where we have to come up with questions for Dr. Powden about more of the case. So do we have any sort of questions, any other tests that we might be thinking, hey, let's look into this?
I want to know if there's a lumbar disc herniation.
Okay. And then you were talking about possible maybe doing some hip testing.
Yeah, definitely hip mobilization. Let's see, do we need an anatomic correction with that? What's going on with the SI? What's going on with the disc? So a low back. Just looking at the low back. I don't know if in the description was there a gastrocsoleus weakness. I don't remember that. But is that a critical component as well? Because if we have the ankle, we have the gait problems. Is there a weakness with it? And if there's a weakness with the gastroc, is it because of a nervous system issue, or is it because of the alterations of the gait and what's caused that alteration of the gait?
She had weak right plantar flexion due to pain, but she had full range of motion.
Yeah, I'm thinking nerve. So there's something wrong with the nervous system that's causing this. So I want to know more about the nervous system. That would be what I would look at. I would look up the chain to see if there's anything that could be causing some descending pain, whether that's an SI joint cluster series or whether it's are we having positive slump test, other positive Valsalva maneuver. Do we have a lumbar disc pathology with this that may be unnoticed?
Mm-hmm.
I would like to know, like previous interventions, what has worked, what hasn't worked, and maybe that's leading to some of our like fear of avoidance, and some of, I don't know, just general stuff. Because if she has a positive anterior drawer, and we're not really like, this isn't an acute injury, I don't know where the disconnect is. But I think that would just be interesting to know what she did in the past if she's had so many.
Fair point, Kristen. Very fair point.
I have to look back in the literature because there was a lot of stuff that I found in my research, but at the strength issue with the plantar flexion, I remember reading something, and I can't remember off the top of my head exactly what it was, but there's some, with individual chronic ankle instability, I think there is some weakness, so that could be associated with the chronic ankle instability. I can go back to literature and look at that.
So what would you guys say for maybe like a patient-reported outcome measure that we could get some information on?
That's where I was going to do.
Fear of avoidance questionnaire.
That's one. Do we want to go to the settlement of the physically active scale? As well as another potential one.
Well, there's the lower limb task questionnaire that has a sport module that I'm using for my practice-based research project. But that's got it's pretty good with fairly competitive and elite athletes, not having that ceiling effect, and so we might be able to get some like some upper level understanding of how she kind of sees her pain.
Yeah, the lower extremity functional scale has quite a bit of that fear tasks in it that corresponds well with the SF36. So that's something that we could have in our toolkit as well. I'll be honest and say I'm not sure which one I would use. I think I need more info, and I probably need to reflect back on a little bit more what pro would be better. So I can't say confidently which one I would go to. Just because of sheer practice, I'd probably use the lower extremity functional scale because I've used it more than others. But I'm not sure that's the best one, because Kristen, I really like your fear avoidance scale, but I'm not sure if that's the best for our patient as well.
Kind of taking a step back, I'm reading more into the case, and it talks about her gait analysis reveals shortened forward stride on the left limb, but then decreased push off length within the right when they're compared bilaterally. I wonder if that has anything to do with like a posterior weakness due to that like sciatic nerve or something like that, like you were saying.
I thought when I was reading it that the pushing off the right foot, so being her front foot's being her left foot, that was shorter, and I attributed that to the strength deficit. Are we all on the same page or do you guys think something different?
The strength deficit. Okay, so decreased push off length with the right. So yeah, just having that strength deficit and with plantar flexion, possibly decreasing that. Is that what you're saying?
Yeah, that was my thought.
Okay, I mean, yeah, that definitely could play into it. When I first read it, I thought like when it was saying shortened forward stride, I was like, oh, that's got to be, maybe it's like she's trying to avoid overstretching the sciatic nerve or over tensioning it, but that's on the left limb. So I think it does have more to do with just that having that weakness and not being able to push off as well with that right foot.
Another question that we should probably ask is what difficulties with her ADLs is she having? Because he just mentioned that she lives on the 5th floor with a 2-year-old. He didn't mention if she has difficulty climbing the stairs, or is it just the like endurance part of her running that she gets pain and stuff with?
Well, she says I was gonna say it like kind of goes away, like it slowly goes away. So I feel like her endurance is fine, but then it hurts her. She has some tightness after, like the rest of the day. So I don't know if.
Yeah, I'm not even sure if she would have any issues climbing the stairs, and maybe that's why he left it out. But it wouldn't hurt to ask if that is something that she's having issues with, and then we can address that throughout the treatment plan next week.
I'm even
yes.
recovery.
Yes.
Say that again, Brian.
I'm almost curious what she does for recovery as well.
Yeah. If anything at all. I mean, she's got to do something though. If she played college soccer, they had to teach her some stuff.
No, I've been in college athletics for 15 years. I've seen one team do an actual full recovery cool down.
Oh, you're saying recovery as in like after her runs and stuff like that. Okay.
Yeah. Otherwise, what I see with my college athletes, more often or not, they go drinking or immediately leave. Oh, don't practice, shower, run as fast as they can away.
Yeah. We need to get her a one of those grandma chairs that just kind of brings her up the stairs. 5 flights of stairs.
That's called an elevator.
Yeah, right. She has a 2-year-old child at home. I'm trying to see if that might play into any of her
bending. Lots of bending with young child. You just saw with my kid. You got to bend down. So if you have a low back issue, you're going to have pain. If you have a foot issue, you're going to trip on many child's toys. So that'd be a fair question to ask. Did she step on a toy around the house that she didn't realize caused something else to go wrong?
The bending can also kind of play into that sciatic.
This is my living room that's clean right now. Do you see lots of things out there?
I see some things.
Yeah, toys galore, and it's actually semi-clean. So Does that play a role? It could be a fair question to ask with a 2-year-old.
Mhm. Gotcha.
Josh and Kristen, do you guys have access to the Google Doc I sent out?
Yes.
Okay, just checking. I'm kind of putting up all our ideas on there as well. So
Do you? Okay, so maybe I'm looking at the Google Doc because I added. I added it to Kristen's thing.
because Sean and I are on the same one. Oh, there's Josh.
I see it. Okay, so this is for the case. I got you.
Mhm.
Right.
Did you send it to my Sycamore's email?
I'll check. I think so.
I don't know where it is.
Hold on. Yeah, it's at your Sycamores. I can reset. Is there another email you prefer I send it to? You're muted.
No, that one's fine. I just don't see it.
All right, I'll send it again. The other thing I can do is I have a email or a link here. I'll copy and just email to you as well.
Yeah, because I refreshed it and I still don't have it.
Any other thoughts about the case?
Yeah. You guys have anything else about questions or anything like that?
With her case, I think he led us down a little bit of a path with the articles that are in the supplemental readings. If you haven't got to them, and it does highlight a little bit of her case, but I'm not sure how to apply them yet. I think I need to reread them.
Mhm.
I sort of scanned before tonight's talk, and it sort of discussed some of those points. So after rereading that might spur some more questions to at least consider for next week's during our treatment plan. But I don't really have anything specifically right now to share. With our assignment for this week, we could probably just maintain do some housekeeping, just add to the Google Doc over the next 24 hours while thoughts are fresh on that to make sure that we clean that up, and so that's ready to go and submitted here, at least by Friday morning, if not tomorrow night. But I think for our own case, I think what we need to do is just take a step back after our discussions, sleep on it, and see if we have any better ideas. And after Dr. Powden's feedback, see where we need to go with this.
Mm-hmm. Cool. I'm game.
I agree. Do y'all have any questions about anything that we talked about today? Any of the techniques or application or anything?
The techniques are very helpful. They're really. I actually used a couple of them in clinic today on the Achilles positional release and the bending. The girl, young soccer lady, was extremely happy that she had full range of motion of her full range of motion of plantar flexion and dorsiflexion that she hasn't had all soccer season. So she was happy with that, just with something very simple. And she didn't like that I told her that she'd still need to do all her rehab exercises, but she'll get over it. So those things it's highly applicable, and you in a high school setting, you're going to get really good results really quickly, I think, with those.
So I guess I have a quick question for you guys that maybe y'all can weigh in. So I have an athlete. He is a sophomore in high school. He's a football player. Last year, he had complaints of pain right at the insertion of the Achilles tendon. And, I thought it was just some kind of tendonitis at the time. He's a short little guy. He's not really grown very much. But I guess recently he's grown a good bit, like over the summer. And he said that the pain is starting to come back. Before, we had just treated it with eccentric exercise and with massage and things like that. But now I'm starting to think that he might have like a Sever's disease type deal going on. So I'm curious if y'all think that maybe doing some of these Achilles tendonitis and type manual therapy techniques and then adding those to doing eccentric exercise and things like that that might help with that, or is something like Sever's disease where it's more of like a growing pain type deal, that maybe we can just help with pain, but he should probably still kind of stay off it?
Get an X-ray.
Yeah.
That's the first thing with my patients that I've seen those in the past. You will get some positive results with your positional release, your bendings, even ankle mobilization. You're going to get really positive results. But as soon as that young man, if he's a short, stocky, moderately heavy young man,
yep,
symptoms are going to come back. And if he's having some bony inflammation, you're going to need to reduce the stresses on that. And you may have to consider putting him into a splint in the evening if it's really severe, or have him when he's walking around, at least put him into a heel cup or some sort of heel lift to keep that pressure off.
Yeah.
So I would caution you on putting him right back into eccentric load until the condition is at least calmed down some. The initial thought with Achilles tendinopathy with that would be the eccentric loading and stuff like that. But with the pediatric case with Sever's disease, if you can get the musculature relaxed in that area, it will be beneficial regardless if it is having a bony inflammatory response or not.
Right.
And I would get an X-ray just so I would have some peace of mind that we don't have something weird going on.
Right. Like a apophysitis type deal. I gotcha. Cool. Well, thank you for your input. That helps me a lot. I mean, I had that conversation with him where I was like, we might need to refer you to see an ortho and possibly get you an X-ray and stuff like that. And I was like, I want to try some stuff on you for the next couple of days and see if we can get some good outcomes. But he still had complaints today, so I thought that was a piece. But cool. Yeah, thank you. That's probably my next step. Well, that's it for me, guys. If you guys don't have anything else.
No, it was good. It was good talk. Have a good night.
Stop the broadcast.